Hello everyone. It's really a great pleasure and honor to be sharing some valuable time with you all to learn about such an important and evolving topic which has been bothering not just us, but in fact the entire NHS as well. These are my disclosure slides. And let's try to learn about this interesting molecule. And if you all come across any adverse events, you all are more than welcome to share such concerns as well. So, now coming to the topic of the day, why is this bothering us? Is it because it is the most common heart arrhythmia? In fact, even now as well, when we'll try to look at the numbers, it is amazing and a little bit surprising and shocking as well that still there's such a huge number of patients who have had stroke are living among us. And in fact, with the passage of time, this is going to only increase not only to just simple numbers, but even complex, huge numbers as well. And when it comes to the social care costs, it is going to increase almost to three times in the coming future. Are we getting prepared for this? The problems which is associated with is not only includes higher mortality but also higher morbidity rates as well. In fact, due to which it tends to limit the discharge rate of the patient, even if they would like to go to the home as well. They still tend to spend higher time, more time in the healthcare setups, in fact. So, even right now, when we are thinking of sending mission to Mars, establishing colonies at Mars and other planets, if when we are thinking about the total percentage of detection of the heart arrhythmia, it is abysmal. Abysmal in the sense there is a huge number of patients which is not just untreated, but also the atrial fibrillation patients who are still undetected as well. So if we try to look out in the data about the number of prevalence while compared to the number of detected in the different areas as well, it is a huge difference. So, indeed, this comorbidity can be more selective towards the selected age group, as we can already see over here. There's a sharp rise in the individuals being in 70s going up to 80s as well. So I always used to say it like this, that it is the incidence of atrial fibrillation alone is going to increase in a drastic way, especially one crosses uh, the age group of around 60s, as you already saw. Over here, when we try to look out for the number of patients who has suffered stroke, there's abysmal huge number of them who is still not on anticoagulation. So if we look over here as well, even for Bedfordshire as well, it is way above the average for the UK over here. So even now and in the future as well, there will be a huge number of people who will be living with stroke, and the cost of stroke as well, how much is being spent about its management, and the prevalence and disease cost as well tends to be very, very high. So, what can we do? So, in simple terms, I always try to talk it to my patients as that atrial fibrillation doubles the risk of dementia, triples the risk of heart uh, triples the risk of heart failure and quadruples the risk of stroke. So, if we will try to look carefully, most of these patients tend to have associated comorbidities, which includes coronary artery disease, congestive heart failure, pulmonary disease, or the CVAs as well. So, they tend to be on also multiple medications for the management of these diseases as well. And we also have to be quite a lot practical about the complex medical history. So they will be having hypertension, which not only increases the risk of stroke, but also the bleeding risk as well. In fact, they also tend to have difficulties like dysphagia and frailty, which is commonly associated with patients in Parkinson's. Similarly, those patients may benefit from dose adjustments for the renal function, as it will tend to get impaired with the progression of age and the comorbidities as well. Similarly, they also start having the onset of dementia and the cognitive decline, which tends to grossly affect the compliance with the medications. So, whenever we are treating someone, we have to keep all these multiple factors in our mind that uh, the renal impairment, the comorbidities, and the swallowing difficulties with dosing frequency will have a significant effect on determining the therapies of such patients. Similarly, the guidelines have endorsed these lines and they have made suitable changes as well, how we tend to treat these patients. So, I'll try to give you a simple example of this gentleman. So, when he was 66, he was having systemic hypertension with good renal functions, and he was detected with asymptomatic atrial fibrillation during the annual cardiovascular disease review. Okay, so he was started on warfarin. After 6 years, we start noticing that his renal functions are declining. He has also developed type 2 diabetes mellitus as well. He's showing earlier signs of dementia. So, to help him, uh, uh, we all are aware about the different advantages of DOACs, for example, like rivaroxaban. So that's why he was switched over to rivaroxaban, because there will be no need for monitoring for this gentleman. How about after 4 years? The wrinkles are becoming more fine, his hypertension is becoming worsening. The type 2 diabetes mellitus as well is needing more agents to monitor, to take care for that. And now he has moved to a care home where there has been incidents of nearly 6 times history of falling as well. Fortunately, he did not have any significant injury. So initially, the rivaroxaban was shifted because sometimes he used to forget taking those medications as well, that it should be taken after food. And in fact, after since due to decline in the renal functions, he was finally moved to a lower dosage of edoxaban. So, what do we feel? If it would be any of my family member, it is always cumbersome to keep on changing those medications. Can we think of something, trying to help this person, where it will be easier to adhere, there will be lesser interaction with the food, it is easy to monitor, and also reduce the frequency. So we try to practice what is called as evidence-based medicine. I think we all will agree, isn't it? So one of the key concepts whenever we are trying to give a medication is the time in therapeutic range, TTR. In fact, the NICE 2021 guidelines, they already said it, is while trying to use warfarin, unfortunately, due to the timing in the therapeutic range, has a significant effect on effectiveness of warfarin therapy for stroke prevention. So therefore, of course, warfarin gets ruled out. That is where the role comes of the DOACs. Not only there's improved adherence, there's better or lesser interaction with the food, or there's predictable effect on the anticoagulation as well, and there's a faster onset and offset of the action as well when this is being used. In fact, now the standard clinical practices as well, even the guidelines as well, they tend to endorse DOACs while compared to the warfarin. And it's a nice slide to go through this, as we can see that it has been continuously on the rise. Although they may belong to the similar group, but on the other side, they are quite a lot a difference. Although there's lack of clinical studies which have tried to head-on compare each of these individual molecules, I still do remember with my some of my colleagues in Australia, when I was based in the Netherlands, we tried to collaborate and we tried to do a comparative study comparing the warfarin with dabigatran way back then, and submitted it and got it published as well in International Journal of Cardiology. So then the editor wrote back to us because that was the time rivaroxaban was already there past just a few years, and we were asked to compare them as well. We compared the data. We again got it published as well, in the International Journal of Cardiology after a few years after that. And even recently as well, I published another study, what is called as U-blood AF study, in which again we try to compare the different NOACs which is used for these arrhythmia patients as well. So now trying to understand, it's an interesting thing is like we are aware there will be a higher group of patients who whose age will increase, their renal functions will come down. So what about the clinical studies? How many of them have studied on the lower dosage of these molecules? Then we notice that there is uh, one molecule which stands out with all of these. And this is a very interesting graph plot when we try to look out for the primary outcomes, especially on terms of stroke or even in terms of major bleed. Then we notice that no doubt about it, DOACs tend to be non inferior. And even in terms of cardiovascular death as well, the DOACs tend to outstand or outshine the warfarin over here. Therefore, the NHS England guidelines tend to recommend Lixiana that it should be preferred where it is clinically appropriate and subject to the criteria specified in the relevant NICE technology appraisal guidance as well. So this is interesting, and indeed, especially for the suitable patients, they are the preferred oral anticoagulants. And as I already summarized before, not only due to the regular dose adjustment, in fact, the routine monitoring of the anticoagulation is not at all required for that. And therefore, in our day to day life, we have to give some practical considerations. What I mean is, for example, whenever a patient comes to our clinic, when we have to think for them and all, we do have to think for the frailty and the risk of bleeding. How about the risk of falls for these people? There are several studies which has been done in the real world of frail patients. One of them was Etna AF study as well, which was a large, multicentric, prospective study across 10 European countries, which were using Lixiana and trying to evaluate about the bleeding events and the drug related adverse events. Um, and as you may already notice over here, that when this was being used, there was significant protection against stroke, and in fact, the incidence of the ICH or the life-threatening bleeding versus warfarin as well was significantly different. The ERA guidelines as well tend to show over here like if some of them tends to develop complications like the bleeding, how do we manage? So if there is a minor bleeding, of course, try to delay or discontinue the next dosage, or maybe if rarely, if possible, just omit the dosage as well. And again, if it is a non-life threatening major bleeding, that is where we have to try to consider for the interventional procedures like the endoscopy or the surgical hemostasis, or if a transfusion fluid replacement, or sometimes the antidotes as well. Similarly, if there's a life threatening major bleeding, that's where we have to try to use the PCC or the idrasuzumab, which is available for the dabigatran, or adnex, adnexanet alpha, which is available for the factor 10A inhibitors as well. Uh, this is a very important slide, is what are the kidney conditions in which, based on the renal function, how we do the dose adjustment. So for example, for Lixiana, if we can already look over here, for 15 to 50 ml per minute of the creatinine clearance, the dosage must be reduced to 30 milligrams, and of course it is not recommended for the decreased creatinine clearance if it is less than 15 ml, which stands true also for the rivaroxaban as well. The other thing, one of the important thing what we all have to look out, especially for dabigatran. So if there's a patient of dabigatran, which is also on verapamil, we will have to be careful and we must come down on its dosage. So on a summary basis, to summarize, if someone is of lower weight, less than 60 kgs, or someone is on uh, concomitantly given medications like dronidrone, erythromycin, or antifungal agents like ketoconazole as well, we have to be really careful for this. And of course, if there's a renal impairment dosage as well. And yes, for end stage renal disease, it is not advised at all. So, as I already gave the indication, if someone is already on anticoagulation, it is not advised to give them this medication. Similarly, on the other side as well, if someone is on anti-platelet drugs as well, there may be higher risk for bleeding. So, if someone is on NSAIDs or SSRI as well, one has to be really, really careful. And as I already gave some of the examples, there are some molecules which may influence the cytochrome P3A4 as well. So something like phenytoin, carbamazepine, or phenobarbital or St. John's wort as well. We need to be really cautious. So now coming to the adherence that we already understand, it becomes difficult for anyone having a dementia or the these kind of problems like the cognitive decline as well, or if there's associated difficulty in swallowing in patients with the Parkinson's. So that's why we must be able to promote the adherence or and to ensure that it is safe and effective medicines are given with those patients. And we should be able to help these patients by modifying it in a better way so that it suits them as well. So that is why, on a normal basis, several studies have shown that once daily dosing tends to reduce the pill burden and may also improve the adherence to treatment while compared to the twice daily dosing. Okay. Now, as I already said, it is yes. The good thing with this molecule is there's need for only once daily dosing, and that is enough. And there's no effect if it is taken with or without food. And for someone who is really finding it difficult, so it can be even mixed with water or apple puree for someone finding it difficult. In fact, its packaging as well, it has been uniquely designed on multiple parameters, not just for easy access, but also for the reminders and easy, like one can access the patient leaflet as well using the QR code, and there's a blister pack message as well, which gives a reminder for the renewal and the multiple factors which make it more patient friendly. So indeed, as we already said, it is there are multiple practical benefits if patients are using this molecule and they try to use it. So switching from vitamin K antagonists to DOACs is pretty easy. One has to be careful about until the INR tends to become lesser than these levels, then we can switch them over. And even while switching over the DOACs as well, it is very simple and easy. You on the respective dosage where it has to be taken, you can just switch over. So, rational ways as well, there are multiple clinical studies, even in the fragile patients as well. There is positive efficacy and safety profile for the clinical practice, and it also tends to support the adherence